Before we dive into today's deep dive, let's just take maybe 20 seconds to anchor ourselves. Take a breath in and a slow breath out. Now try to recall one patient encounter where you made a difference, even if it felt small. Just hold on to that feeling of impact. That's why you're here, right? That's why you're studying. Let's make every minute count. Okay, imagine this scenario. You're on shift and a patient comes in. Let's call her Mrs. Albright. She's got a fever, a productive cough, and maybe you hear those distinct crackles on auscultation. So what's your first thought? Is it pneumonia? But like, what if she's 65 and has COPD? Or maybe she was just discharged from the hospital, say, 48 hours ago. Lower respiratory tract infections, pneumonia, bronchitis, all that, they can look deceptively similar, but they demand really sharp decision-making. So in this deep dive, we're going to walk through treatment strategies, those clinical scoring tools, and the antimicrobial choices you absolutely need to know cold, all aligned with the NAPLEX blueprint. Let's level up your clinical reasoning and sharpen your test day readiness.
So by the end of this, you should be able to confidently identify key pathogens, tell the difference between CAP, HAP, and VAP, that's community-acquired, hospital-acquired, and ventilator-associated pneumonia. You'll be selecting appropriate empiric and targeted antibiotics based on those crucial patient risk factors. We'll touch on when to use scoring tools like CURB-65 or PSI. Maybe not the deep details of the scores themselves today, but definitely their role. And critically, how to monitor and adjust therapy based on labs, cultures, and how the patient is actually doing. And yeah, throughout this, we'll definitely make sure to clearly pronounce key medications and drug classes, say them nice and slow to help them stick. Okay, let's unpack this then. We're diving into lower respiratory tract infections, LRTIs. So just basically, what are we talking about here? Why is this whole area so important?
Yeah, good place to start. So LRTIs are infections happening below the larynx. Think bronchitis, bronchiolitis, and the big one for us today, pneumonia. They usually happen when viruses or bacteria invade the lung tissue itself. Now, viral infections, often diagnosed clinically, right? Mostly supportive care, unless it's influenza or COVID-19 where we have specific treatments. But bacterial LRTIs, especially pneumonia, that's where you need the right antimicrobial therapy and fast. That's where those sharp decisions really matter.
Right. So bacterial pneumonia is our main focus. How do we actually define that?
Yeah.
And why all the different categories?
Okay, so pneumonia itself is basically inflammation of the lung where the air sacs fill up with like fluid or pus. We call that consolidation, and you can often see it on a chest x-ray. But the key thing, the real game changer for treatment, is classifying it based on where the patient got it. That gives us our main types: community-acquired, CAP, hospital-acquired, HAP, and ventilator-associated, VAP. Knowing the difference is just. It's vital for picking the right starting antibiotic, the empiric therapy, because the likely bugs are totally different depending on the setting.
That distinction, CAP, HAP, VAP, sounds like it's absolutely fundamental. Before we jump into the drugs, can you walk us through how these infections usually get started? Like, what's physically happening?
It's pretty interesting, actually. Normally, our lower airways don't have many bacteria, but if enough bugs get down there, pneumonia can start. There are three main ways they get in. The biggest one is aspiration of stuff from the mouth and throat or pharyngeal secretions. Even tiny amounts, what we call microaspiration. That's the major route. Second is inhaling aerosolized particles, just breathing in the germs. And third, less common, is spread through the bloodstream from an infection somewhere else. Metastatic spread. We have pretty good defenses normally. Mucus, cilia moving things up, nasal hairs, antibodies like IgA. And lower down, the cough reflex is huge, plus more antibodies and special immune cells called alveolar macrophages. Infection really only happens when these defenses fail or get overwhelmed. When that happens, you get inflammation. It can stay local in the lungs, or, if it's bad, it can become systemic. Sepsis.
Okay, so defenses fail, pneumonia happens, but who gets what type? This seems like where it gets really practical for choosing that initial treatment. Let's talk bugs. Which ones are we worried about for each type?
Exactly. So for community-acquired pneumonia, CAP, we're thinking about bugs that are just out there in the community. The number one bacterial cause you absolutely have to know: gram-positive streptococcus pneumonia, strep pneumo, that's the big one. Then you've got some common gram-negatives: Haemophilus influenzae H flu and Moraxella catarrhalis. And then there are the atypicals, things like Mycoplasma pneumonia, Chlamydophila pneumonia. These often cause milder walking pneumonia sometimes, but don't forget Legionella pneumophila. Rarer, but can be really severe. Oh, and viruses are super common too, especially in kids. RSV, flu, COVID. And in adults, they can co-infect with bacteria.
That brings up a really important point. What about patients with other health problems, like comorbidities? How does that change our thinking for CAP?
That's a great question. And yeah, it changes things quite a bit. Patients with comorbidities think chronic heart, lung, or kidney disease, diabetes, alcoholism, cancer, no spleen, they're at higher risk for worse outcomes. And importantly, they often interact more with healthcare settings, right? So they might be exposed to more resistant gram-negative bugs. So if someone has COPD, for example, we might need broader coverage than just for typical strep pneumo. Now, shifting gears to the hospital. Hospital-acquired pneumonia, HAP, and ventilator-associated pneumonia, VAP, the key insight here. Patients in the hospital, especially on vents, tend to get colonized with the bacteria that are common in that hospital. And because of all the antibiotic use in hospitals, these bugs are often much tougher, more resistant. We're mainly worried about Staphylococcus aureus, including MRSA, methicillin-resistant Staph aureus, and the gram-negative Pseudomonas aeruginosa. Those are the big players. So for HAP and VAP, figuring out the patient-specific risks is crucial for picking empiric antibiotics. For MRSA risk, did they get high IV antibiotics in the last 90 days? Is the pneumonia happening in a unit with high MRSA rates, maybe over 20%? If you don't know the rates, it's probably safer just to cover MRSA. For gram-negative risk, especially Pseudomonas, does the person have underlying structural lung disease, like bronchiectasis or cystic fibrosis? That bumps up the risk. And if the patient is really sick needing vent support because of the pneumonia, or they're in septic shock that's a higher mortality risk, you need broader coverage then too. For VAP specifically, just being on the vent for more than 48 hours is itself a major risk factor needing specific coverage.
Okay, that's a clear breakdown of the risk factors. Let's try a quick pause and think question based on this. Imagine a 67-year-old with COPD. Comes in with shortness of breath, fever, new infiltrates on the chest x-ray. Key piece of history. Hospitalized 3 months ago for heart failure. So what's the best empiric treatment here? A, amacicillin, B, azithromycin, C, ceftriaxone plus a zithromycin, or D, vancomycin plus piperacillin lintazobactam. Pause and think.
All right, the answer there is D, vancomycin plus piperacillin lintazobactam. Why? That recent hospitalization, even 3 months ago, is the big clue. It puts them at risk for AP or at least healthcare-associated bugs. So you need that broader coverage, definitely hitting MRSA and Pseudomonas. Vancomycin covers MRSA, and piperacillin tazobactam, or Zosyn, covers Pseudomonas plus other gram-negative and strep pneumo.
Got it. That really drives home how important the history is. Now, what about aspiration? We hear about aspiration pneumonia, but is it always an infection?
Good point. There's a really important distinction. You have aspiration pneumonitis, which is a chemical injury, like a burn, from stomach acid getting into the lungs. It's not bacterial. Most acute breathing problems after someone aspirates are actually pneumonitis. Then you have true aspiration pneumonia. This happens with a larger volume aspiration, often involving anaerobic bacteria from the mouth or stomach, like Bacteroides fragilis. This is an infection and can lead to things like lung abscesses. Risk factors for true aspiration pneumonia usually involve problems swallowing, like from a stroke, seizures, or heavy alcohol use.
Okay, so we know the risks, the likely bugs.
Yeah.
How do we actually nail down the diagnosis? And then what's the first move for treatment? Those initial hours feel critical.
Definitely. Patients usually come in with respiratory symptoms, cough, could be dry or productive, shortness of breath, maybe working hard to breathe. And non-respiratory stuff too, fever, feeling wiped out, sweats, headache, muscle aches. And importantly, especially in older adults, confusion or mental status changes can be a big sign. On exam, you might find a fever, fast breathing rate, maybe hear decreased breath sounds. But the absolute key for diagnosing bacterial pneumonia, imaging. You need a chest x-ray or a CT scan showing an infiltrate, that area of consolidation. Without that, it's technically not bacterial pneumonia. There are lots of tests we can do, but let's focus on the essentials. Confirm with imaging. Try to get culture sputum, blood before starting antibiotics, if you can. Remember those nasal swabs for MRSA PCR? Great for ruling out MRSA pneumonia, high negative predictive value, like 99%. But not so good for ruling it in low positive predictive value, maybe 35%. So useful, but know its limits. Basic labs like a white blood cell count can help too. Procalcitonin is often ordered, but guidelines don't really recommend relying on it heavily because its accuracy isn't great.
That's a practical approach to the workup. Okay, the crucial part. Empiric treatment. What's the philosophy here? Getting started quickly but smartly.
Exactly. The goal is simple. Clear the infection, stop symptoms, prevent complications, and save lives. Empiric therapy means we're making our best guess based on the patient's presentation and risk factors. We target the most likely pathogens, but we try to use the narrowest spectrum antibiotic that should work to minimize side effects and, prevent resistance down the line. It's that calculated first step.
All right, let's get into the specific regimens, starting with the most common scenario. Community-acquired pneumonia, CAP.
Okay, for CAP, outpatient, no significant comorbidities.
The main target is strep pneumo. First line choice. High-dose amoxicillin. That's amoxicillin. Amoxil. If they're allergic to penicillin, then doxy clean is a good option. doxyclmin. Fibromycin. Third line, maybe if allergic to both, could be azithromycin. azithromycin. Zithromax CPAC. But a really important point here. There's a lot of strep pneumo resistance to macrolides like azithromycin now because they've been used so much. So using it alone isn't generally recommended unless local resistance rates are known to be really low, like under 25%.
Good point on the resistance. Okay, quick check again. Outpatient CCOP, no comorbidities. Which agent is preferred? Oh, A, SI Pro, F, LOXCCAT, B, doxy clean, C, CCPEM, or D, lenin-izolate.
That would be B. Doxy clean. Remember, ciprofloxacin is a fluoroquinolone. Generally avoid first line. Supapime is for HVVP. Linezolid is for MRSA. Doxycycline is a solid choice here if amoxicillin isn't used. Now, what about CPRP, outpatient, but with comorbidities, like our patient with COPD? Here, we need to cover more bugs. Strep pneumo, yes, but also H flu, M. catarrhalis, and those atypicals, Mycoplasma chlamydophila. So the recommended approach is combination therapy. Usually a beta-lactam like a amoxicillin clovulan, augmentin, or an oral cephalosporin like cefpoe, doxime, Vantin. And here's the key insight. You must add something for the atypicals because those beta-lactams don't cover them. So you add either azithromycin or doxycycline. An alternative is monotherapy with respiratory fluoroquinolone like levofloxacin, levaquin, levofloxacin. But again, we really try to avoid fluoroquinolones if other effective options exist because of their side effect profile. Remember the memory hook. Doxy if you're healthy, dual if you're sickly. Moving to inpatient COP, non-ICU. The bugs we're targeting are pretty much the same as outpatients with comorbidities. But since they're in the hospital, we usually use IV meds. So a common regimen is high-V-Cef, TRIX1, Rosifin, CEF, TRIXONE, or ampicillin insulbactamimicin, plus as again coverage for atypicals. Or oral azithromycin or doxy-clean, and same caution about fluoroquinolones, avoid first line if possible.
That's super clear, linking the setting, risks, bugs, and drugs. Now, the hospital setting. HAP and VAP, where we expect those? Hospital nasties, right?
Exactly. KPAP equals community bugs. HAP equals hospital nasties. That's a good way to think about it. Okay, for HAP, with no specific risk for MRSA or nasty gram-negatives, we still need to cover strep pneumo, but also need baseline Pseudomonas coverage. Common choices here are broad-spectrum agents like piperacillintazobactam, so piperacillin, tazobactam, or cefepime, maxipime, CEFEPIME, or maybe levofloxacin. Now, if that patient does have an MRSA risk, remember IV antibiotics in 90 days, high unit prevalence, you add specific MRSA coverage. That means vancomycin, vancomycin, or linezolid Zyrox, linezolid. And here's a key NAPLEX pearl again. Don't use daptomycin for pneumonia, lung surfaction, and activates. A crucial point. Okay, what if the AP patient has gram-negative risk, especially for Pseudomonas, like someone with cystic fibrosis? Then you need double coverage for Pseudomonas, 2 drugs with different ways of working. So you'd use one of those baseline broad agents like Zosyn or Sapopime, and I got a second anti-pseudomonal drug. Good options for the second drug are often an anti-pseudomonal fluoroquinolone like SI-profloxacin, Cipro, or levofloxacin, or an aminoglycoside like gentamicin, garamicin, tobermicin, Tobrix, or amikacin, Amikin. So a regimen might look like cefepime and tobermicin, for example, and finally, the broadest coverage. For HEP with both MRSA and gram-negative risk, or if the patient has that high mortality risk, needs vent support, septic shock, or for basically any VAP, your empiric regimen needs to hit everything. MRSA coverage and double coverage for Pseudomonas. So an example might be piperacillintazobactam for Pseudomonas and others, plus vancomycin for MRSA, plus maybe tobermicin as the second anti-pseudomonal agent. It's broad but necessary in those high-risk situations. Remember, no ICU, no dual anti-pseudo. That helps distinguish the need for double coverage.
Wow, that's a really systematic approach to some complex decisions. So quickly, what about true bacterial aspiration pneumonia?
Right. For that specific case where you suspect anaerobic involvement due to large volume aspiration, you typically add an anaerobic agent to your standard CKP coverage. So maybe metronidazole, flagyl, metronidazole, or clindamycin, Cleocin, CLNDAMYCIM, added onto, say, ceftriax1 and azithromycin. But remember, small aspirations, probably pneumonitis, are often just treated like COP.
And viral pneumonia, is it always just rest in fluids?
Not always. It depends on the virus. For most viruses causing pneumonia, yes, it's supportive care. But for influenza, we do have antivirals. Need to start them ideally within 48 hours of symptoms. Outpatient, the most common is oral oseltamivir, Tamiflu, Oseltamivir. There's also inhaled zanamivir, Relenza, or single-dose oral bel-elixavir, Xofluza. Inpatient, usually oseltamivir. If they can't take oral, IV peramivir, Repivab, is an option, Peramivir. And for COVID-19, antivirals or other treatments should generally start within 7 days of symptoms. Outpatient first-line options are oral nirametrelvir-ritonavir, Paxlovid, that's Nirmatrelvir, RTONAVIR, or ILNU-PRAVIR. Big point. Dexamethasone is not recommended for outpatient COVID. But for inpatient COVID, oral or IV dexamethasone actually decreases mortality, and remdesivir can shorten the hospital stay. So different strategies depending on severity and setting.
Okay, that covers the initial treatment choices extensively. What about the bigger picture? How long do we treat? What are we monitoring? And can we prevent these infections?
Good questions. Duration of treatment, the mantra is keep it as short as effectively possible. For CP, it's usually about 5 days. For Hate VA, typically 7 days. The key things to look for before stopping antibiotics. Patient needs to be fever-free for about 48 to 72 hours and clearly getting better, clinically breathing easier, less cough, etc. If they're improving slightly or have complications like bacteremia, you might need longer. And of course, if you get culture results back, identifying a specific bug and its susceptibilities, you should definitely narrow or adjust therapy based on that. Targeted therapy is always best. Quick mention for pediatric bacterial pneumonia, bugs are similar to adult CAP. But the big no-nos, fluoroquinolones and tetracyclines like doxycycline are generally avoided in kids due to risk of cartilage issues or teeth staining, respectively. So you're often looking at high-dose MLX-icillin, maybe second or third gen cephalosporins like cefuroxime or cefpdui-doxime or Iving-ceftriaxone, azithromycin for atypicals. And that critical neonate warning again. Ceftriaxone is contraindicated in infants less than 1 month old because of the risk of biliary sludging and precipitation with calcium. Really, really important safety point. Can be fatal.
Those pediatric points are crucial. And speaking of safety, let's quickly recap some key side effects or monitoring for the drugs we've mentioned. The really high-yield stuff.
Okay, rapid fire. Azithromycin, QTC prolongation. Watch the EKG, especially with other QTC prolonging drugs. Doxycycline, photosensitivity till patient sunscreen. And interactions with calcium, iron, antacids separate the doses, generally avoid in pregnancy. Beta-lactams like amoxicillin, ampicillin, piperacillin, tazobactam, rash, GI upset, C. diff risk, allergies, need renal dose adjustments. Piptazo doesn't cover MRSA and can rarely cause bleeding issues. Ceftriaxone, no renal adjustment needed, which is nice. But avoid in neonates, especially hyperbilirubinemia ones or with IV calcium, cefepime. Neurotoxicity risk, like seizures if the dose isn't adjusted properly for kidney function. Fluoroquinolones, Melobican Cipro. The big ones are the black box warnings, tendon rupture, neuropathy, CNS effects. Also QTC prolongation, blood sugar issues. Just use caution and alternatives when possible. Aminoglycosides, gentamicin, tobramycin. Kidney damage, nephrotoxicity. Hearing balance damage, ototoxicity, nerve damage, neurotoxicity. Need to monitor drug levels closely. Vancomycin, red man syndrome, infusion reactions, slow the rate. Kidney toxicity risk, watch BUNCR. Otoxicity, less common. Monitor levels. Linezolid. Bone marrow suppression, low platelets, anemia, especially with use over 2 weeks. Check CBCs. It's also a weak MAO inhibitor, so watch for interactions with SSRIs, sympathomimetics, tyramine foods, risk of serotonin syndrome or hypertensive crisis. Metronidazole, metallic taste, peripheral neuropathy with long use. Disulfiram reaction with alcohol, no drinking. Clindamycin, highest risk for causing C. difficile infection.
That's an excellent practical rundown of key safety points. Let's try one more quick question related to that. A patient is on L-Zule for MRSA pneumonia and develops thrombocytopenia, low platelets. What's the pharmacist's most appropriate action? A. Switch to vancomycin, continue L-Zule and monitor closely. C. Add filgrastim to boost platelets. Or D. Stop all antibiotics immediately.
Okay, think about it. The best answer here is A. Switch to vancomycin. Thrombocytopenia is a known significant side effect of linezolid, especially with longer durations. Continuing it isn't ideal. Filgrastim doesn't address the cause, and stopping all antibiotics isn't appropriate if they still need MRSA coverage. Switching to vancomycin is the logical move.
Makes sense. So finally, prevention. What can we do?
Prevention is huge. Number one, vaccines. Get the S pneumonia vaccines, different types for kids and adults based on risk. Get the annual flu shot. Get the COVID-19 vaccine series and boosters as recommended. And now there's an RSV vaccine, too, recommended for pregnant individuals to protect the baby or for adults over 60 as a one-time dose. Beyond vaccines, it's the basics. Hand hygiene, especially in hospitals. Covering coughs. Masks in certain settings. In the hospital, simple things like keeping the head of the bed elevated for ventilated patients can help reduce VAP risk. Oh, and briefly, bronchitis and bronchiolitis, those are usually viral inflammation of the airways, not the lung tissue itself. Typically self-limiting, supportive care. RSV is a big cause in little kids.
Perfect. Let's recap then. You've now got really a solid toolkit to assess, diagnose, and treat pneumonia with more precision. From thinking about outpatient amoxicillin for simple CAP, all the way up to that ICU-level double coverage for Pseudomonas plus MRSA coverage for VAP, you're better equipped to handle it. Remember how those subtle differences in patient history, comorbidities, and where they got sick completely changed the game for empiric therapy? Think about Mrs. Albright. Her recent hospitalization was the key. It's definitely complex, but hopefully this framework helps you navigate it. In our next deep dive, we'll tackle tuberculosis and other atypical infections. Until then, stay sharp, stay curious, and keep learning.